berbakti pada negara, bersatu berjuang untuk meningkatkan derajat kesehatan jiwa. PDS KJI milik bersama, saling berbagi pada sesama, berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbakti, mengabdi pada ibu pertiwi.
Minyak dan suara.
Selamat sore kepada yang terhormat Dekan, Wakil Dekan, eh, semua lecturer dan sivitas akademi dari FK UKWMS, pada seluruh peserta yang sudah hadir di sini, kemudian untuk narasumber dan moderator kita, Dr. Nur Fitria dan Dr. Jose, and also a very warm good morning to Professor Khalid Asaf, also our speaker for today, who's currently joining us online from Germany. I would like to welcome each and every one of you today webinar to commemorate the 11th anniversary for our Widya Mandala Surabaya Catholic University School of Medicine. The title for today's webinar is Updates in Common Dermatological Tumors Seen in Primary Care. My name is Dr. Dave Gerald Unata, and I'm your host for today. I would encourage all participants to turn on the camera. Before we start our webinar today, allow me to start with a prayer. Would please Dr. Alvin lead us in prayer?
Thank you, Dr. Dave. Ladies and gentlemen, let us bow our head for a moment, pray to God so that our international conference can be precious to all of us. I will lead this prayer based on the teaching of Christians, and those who are not the same, you are pleased to pray according to your beliefs. Let's pray. Good morning and good evening, Jesus. Today in Saturday, April 9, 2022, in this beautiful place at Zoom meeting, we gather here to bring about an international conference. The theme is update in dermatological skin tumors in primary care practice. Make this international conference as useful science assembly, as a medium of sharing useful ideas, knowledge, and experiences of scholars, researchers, and students of various disciplines. May the conference we organize today benefit to our lives, broaden our knowledge, shine our ideas, and lead us to be successful, productive persons, which in turn will boost dignity of our nations. Oh God, guide and bless our hearts and our minds with the light of your guidance. Impart your supreme wisdom upon our activities. Help us to speak our minds clearly, help us to listen to each other, respect and love each other so that we are included to the blessed persons. God, protect us from unintended temptations, show us the right path, and give us knowledge and strength to perform good things. Equally, show us and make it clear the bad things and give us knowledge and strength to avoid them. In the name of Jesus Christ, we pray. Amen.
Thank you, Dr. Alvin. And we now would like to sing our national anthem, Indonesia Raya. I would like to encourage all the participants to take a respectful stance. Would the IT team assist us?
Indonesia, tanah airku, tanah tumpah darahku. Di sanalah aku berdiri, jadi pandu ibuku. Indonesia, kebangsaanku, bangsa dan tanah airku. Marilah kita bersatu, Indonesia bersatu. Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah badannya untuk Indonesia Raya. Merdeka, merdeka, tanahku, negeriku yang ku cinta. Indonesia Raya, merdeka, merdeka, hiduplah Indonesia Raya. Indonesia Raya, merdeka, merdeka, tanahku, negeriku yang ku cinta.
We now would like to listen to Professor Paul Tahalele, the Dean of the Medical School, to convey the greeting. To Professor Paul, the time is yours.
Ya, selamat sore dan salam sehat, salam sejahtera untuk semuanya. Yang saya hormati Dr. Puji Januarto sebagai Direktur dari Rumah Sakit Pendidikan Utama Fakultas Kedokteran Universitas Katolik Widya Mandala Surabaya, para teman sejawat sekalian, dan juga para wakil dekan, serta para guru besar, serta dosen yang saya hormati. Puji syukur kehadirat Tuhan Yang Maha Kuasa bahwa sampai saat ini kita masih diberi kesempatan untuk berkarya dan menjalankan tugas sehari-hari dalam rangka mendidik para calon-calon dokter di Fakultas Kedokteran kami yang kami cintai bersama ini. Saya ingin mengucapkan selamat menunaikan ibadah puasa bagi teman-teman yang menjalaninya, khususnya Dr. Puji dan Dr. Nur Fitria sebagai moderator. Semoga kita dalam keadaan sehat walafiat dan segala sesuatu dimudahkan oleh Tuhan Yang Maha Esa. Izinkan saya untuk menyapa Profesor Khalid ya. Dalam bahasa Inggris, saya kira intinya adalah saya ingin mengucapkan terima kasih dan juga ingin membangun kerjasama dengan para dokter-dokter spesialis, experts di luar negeri sehingga bisa membuka wawasan terutama bagi para mahasiswa kita dan juga teman-teman kita sekalian dokter di Indonesia. Good morning, Professor Khalid Asad. That's my dear colleague, Professor Khalid Asad. How are you?
Fine, thank you, thank you.
Okay, yes. Today we have a special guest lecture, Professor Khalid Asad from Krefeld Hospital, Germany. It's like in Düsseldorf, yes, Professor Asad, Düsseldorf. This is a
Yes, very close to the
city, yeah, not than Frankfurt, yes. And thank you very much for your participation and contribution for that seminar. And I hope that this seminar can make us open-minded to know your development in dermatology in Germany. And it is good for our student, medical student, and also our lecturer. On behalf of Faculty of Medicine, Widya Mandala Catholic University, as a dean, I would like to address my warm welcome to this seminar. Thank you for your contribution as a speaker, and I hope we can further cooperation to make development our institution in the future. And I suggest that this cooperation can make our institution more better and better. Once again, thank you very much, and stay safe, stay healthy. Greeting from Indonesia, Professor Khalid, and I hope you are all still health and also happy fasting. Thank you. Saya kira itu adalah sambutan saya. Semoga kita semua dalam keadaan berbahagia dan sehat di bulan puasa ini, bulan Ramadan ini. Terima kasih untuk semuanya.
Next, we would like to listen to Dr. Puji Januartono as the head of the PHC Primary Teaching Hospital to convey the greeting. To Dr. Puji, the time is yours.
Terima kasih, Mas Dr. Dev. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirrahmanirrahim. Pertama-tama, marilah kita panjatkan puji syukur kehadirat Allah SWT bahwa di sore hari ini atau pagi di Jerman sana, kita semua dalam lindungan Allah, dalam posisi sehat walafiat. Pertama, selamat Prof. Paul, luar biasa Prof. Acara yang luar biasa, ini saya mengikuti yang kedua kali. Jadi saya apresiasi buat dekanat FKWM karena pemikirannya jauh ke depan. Jadi luar biasa Prof. Jadi dengan ini maka akan membiasakan murid-murid atau mahasiswa itu untuk sudah berpikiran global, mendunia. Apalagi ya minimal belajar bahasanya Prof. Beda dengan saya dulu Prof. Jadi jauh ya, seperti ini ya. Jadi dengan seperti ini maka harapan saya FKWM maju terus Prof, berkembang terus, makin diminati. Karena mohon maaf kemarin saya sempat berbincang dengan Fakultas Kedokteran di tempat yang lain di Surabaya ini untuk mengisi kuota separuh dari kapasitas saja kesulitan. Ya, karena memang ya itu Prof. Jadi kalau dilihat dari FKWM Prof sampai nahan-nahan supaya kualitas pendidikannya bagus, sampai nahan-nahan mahasiswa, tetapi di tempat lain untuk mengisi kuota aja bisa mampu separuh aja. Nah ini sekali lagi apresiasi dari kami Rumah Sakit PHC karena pendidikan di bawah Prof. Paul dan teman-teman yang lain, sejawat yang lain luar biasa di FKWM. dengan salah satu acara ininya internasional webinar ini salah satu upaya untuk meningkatkan kualitas pendidikan yang ada. Jadi sekali lagi apresiasi buat semuanya, selamat berwebinar, mudah-mudahan Allah Ta'ala memudahkan dan meridhoi apa yang kita kerjakan sekarang. Mohon maaf, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore.
Terima kasih, Dr. Puji. Terima kasih.
Thank you to Dr. Puji for the remarks. We now would like to continue to the main scientific session. And this session will be moderated by Dr. Nurfitria Ikaputri. She's a dermatologist at PHC Primary Teaching Hospital. Allow me to read her curriculum vitae before that. So, Dr. Nurfitria Ikaputri is a clinical instructor at the Dermatology Department, Medical Faculty of Vidya Mandala Surabaya Catholic University. And she's also a dermatovenerologist at the PHC Hospital, Mitra Keluarga Kenjeran Hospital, and Kanani Clinic, Surabaya. This is her educational experience. She was graduated in 2006 from the Erlangga University, and her specialty training was undertaken at the same university from Erlangga University, and she was graduated at 2012. Her organizational experience, she is now part of the Perdoski Surabaya, which is the Indonesian Society of Dermatologists and Venerologists. And she is in the Committee in Social Department and also Committee in Public Relation and Informatics Department. To Dr. Nurfitria, we would like to welcome you, and the time is yours.
Okay, thank you, Dr. Dev. Bismillah, Assalamualaikum warahmatullahi wabarakatuh. Good evening and best wishes to all participants. In this evening, I will act as a moderator. And today there will be two great speakers who will present. The first speaker is Dr. Jose L. Anggowarsito, dermatologist, who will present a topic with the title Diagnosis and Management of Benign Skin Tumors. And the second speaker is our guest speaker, Professor Dr. Met Khalid Asaf, medical doctor, PhD, who will present a topic with the title Diagnosis and Management of Malignant Skin Tumors. At the end of the session, after two speakers have presented their topic, a discussion will be open. So for the participants who want to ask, you can write your question in the chat column below. But don't forget to mention your name and your institution. Okay, let's start with the first speaker. Good evening, Dr. Jose.
Good evening, Dr. Fitria.
Okay, before you start the presentation, maybe I will read your curriculum vitae first. Okay, Dr. Jose L. Anggowarsito, dermatologist. He is a head of dermatovenerology department, medical faculty, Vidya Mandala Surabaya Catholic University. He also dermatovenerologist, dermatosurgery and laser medicine at National Hospital and Orthopedic and Traumatology Hospital Surabaya. Okay, this is the education. He graduated from medical doctor from Atmajaya University, Jakarta, Indonesia. He also postgraduate diploma in dermatology from National University of Singapore. And he graduated dermatovenerologist degree from Samratulangi University, Manado. He also first class KKI Lemhanas RI Jakarta at 2014. Okay, so many. He is a fellow in International Society Cosmetic and Laser Surgeon. He also alumni National University of Singapore, alumni National Skin Center medical practitioner, regular member of Indonesian Dermatologist Association, alumni KKI. He also member of Ikatan Kedokteran Laser Indonesia, Indonesian Skin Surgery and Tumor Study Group, and also Indonesian Dermatology and Venereology. Okay, please, Dr. Jose, you can start the presentation, and you have 40 minutes ahead.
Thank you, Dr. Fitria, for the opportunity. Greeting for our honored Dean, Prof. Paul, and our head of primary teaching hospital, Dr. Puji, our distinguished guests of Prof. Khalid Asad, friends, colleagues, and all participants. Thank you for this opportunity for sharing this knowledge. My topic is update in diagnosis and management of benign skin tumor, what GP should know. Next. Next, please. Yeah. We will discuss all about the several key questions. What is this? Really a skin cancer or skin tumor? And what its types are? What are the signs of non-melanoma skin cancer? And what about another skin spot? So what are the risks and how common I spot a skin cancer? Which health professional will be, and we also will discuss an updated diagnostic tool and management options and how to live your life after the treatment. So next, please. So first of all, what is this really a skin cancer? Skin cancer is a disease of the skin cells. The skin cells constantly makes a new cell to have renewal and replace worn out tissue and heal injuries. Normally, the cells multiply and die in orderly way, but each new cell replaces one loss. But the skin cancer is become abnormal and keep growing. The cells may turn into a cancer. Yeah, the abnormal cell form a mass and lump called a tumor. Next. Not all tumor are cancer. Benign tumor tend to grow slowly and usually not metastasis. A cancerous or malignant tumor may potentially have a metastasis to the nearby tissue, to the hematologenic and lymphatogenic into other parts of body. So basically, the primary carcinoma and the secondary should be called a metastasis carcinoma. Next. Melanocyte is informed located at the basal cells, or we call it membrane basalis, which produce a dark pigment called melanin. So the function is when the skin exposed to UV radiations, melanin protects skin from getting burned. Melanocyte can also found in the navy. Why we discuss melanocytes? Sometimes the skin cancer is developing from the melanocyte. We call it melanoma. I will discuss more further with the professor. So the UV radiation also the main trigger to make the pore differentiation and pore changes from the skin cell into the pre-malignant or malignant. Next. The first most common, we call it basal cell carcinoma. I will discuss this a bit more, not too deep, because it will discuss more with Professor Asad. So basal cell carcinoma is grow slowly, monthly or yearly, rarely metastasis. If left untreated, some BCC can grow deeper to the skin, inflate and damage any bad tissue. Having one BCC increase the risk to getting another. So multiple BCC may occur, and more common in above 40 years old. You can see the graphic from here. So if this is classical for the BCC, have a central ulceration and rolling border. So we can see that abnormal growth from the cell from the membrane basalis, that's called basal cell carcinoma cell. Next. So what types are there? So the most common is basal cell carcinoma that we can always found in the practice, or squamous cell carcinoma too, known as SCC. The melanoma is a carcinoma from the melanocyte that I mentioned before. We will discuss further with the professor. It is a bit more skin cancer that aggressively having a metastasis. The others would be in Merkel cell carcinoma and angiosarcoma. Next. Squamous cell carcinomas grow more quickly, more rapidly than the basal cell carcinoma. we know as a power in situ. If SCC is in situ, it's called more invasive SCC if they are trying to spread and metastasis through the membrane basalis. So its starting point, the squamous cell carcinoma is basically in the squamous cell and the superficial layer in the epidermis. So if left untreated, it becomes metastatic. So SCC on the lips and the ear is more likely to spread out. SCC occur mostly above 50 years old. So we can see here in the picture, so squamous cell is an upper layer. The upper layer from the membrane basalis is actually at the epidermis. It grew a bit more rapid and abnormally. Next. So what are the signs non-melanoma skin cancer? So basal cell carcinoma develop in an area which get more sun exposure. It appears like a pearl color lump and slightly scaly area and shiny pale and bright light. For the darker skin type color, it may be basalioma or basal cell carcinoma in a bit more darker color. It may having a central ulcerations and can more bleed and inflamed. It can heal and repeat it again and recurrent to have an inflamed and wound again. But the squamous cell carcinoma usually appears in a part of the body often exposed with the sun, such as in the head and the neck and the hands, forearms, and the lower legs. But it can start in everywhere. Often appears as thick red scaly grass spot, a rapidly growing lump. It may bleed and become inflamed. Right? So it's from the graphics you can see it's a bit more differentiated for the squamous cell. So basically, it started at the squamous cell layer at epidermis and grew and abnormally it may penetrate and invade lower from the membrane basalis. We call it invasive squamous cell carcinoma. It may metastatic. But the basal cell carcinoma, it started in the membrane basalis cell, which grew abnormally. From the melanoma, the most malignant skin tumor is started from the melanocyte. Next. The other, we call it Merkel cell carcinoma. It's a very rare aggressive skin cancer in sun exposed area. It may form the painless, fresh-colored, bluish-red nodule, often in the face, head, and neck. It's common in older people and immunocompromised. So, the starting point of the Merkel cell is also in the membrane basalis cell. It's grow up normally with a nerve ending denervations. Next. The other soft tissue, a bit more rare, soft tissue sarcomas, or it is started from the endothelial cells. So you're having a poor prognosis, it can arise everywhere in the body. So usually in the elderly, can involve head and neck and particularly on the scalps. So basically, starting point is not on the squamous cell or the membrane basal cell or the melanocyte, but it started from the endothelial cells. Next. So the picture can see a very big difference about basal cell, squamous cell, melanoma, and Merkel cell. Next. What about other skin spot? So some skin spots appear on the skin are not cancerous. It's called benign one. It may grow to be pre-malignant one. So started with the sunspots more common is actinic, or so we call it solar keratosis. It's more common more often in 40 years old, appear in sun exposed area. Sunspots are a warning sign that skin that had too much sun exposure. And rarely, sunspot it may grow into the squamous cell carcinoma or other pre-malignant lesion. Next. Moles or navy. A mole or navy, a normal growth that develops when melanocyte grow in groups. Yeah, very common. Over exposure to sun, especially in childhood, it may also increase the number of the moles. People with large number of normal moles can have a higher risk of melanoma. You know that melanocyte navy, we divided in 3 groups of junctional navy, compound navy, and intradermal navy. So it may having a potential risk if we play them in the sun exposed area, then it can change also the characteristic and become a pre-malignant lesion. Next. So people who have many irregular moles, so we call it dysplastic nevi. The greatest risk of developing melanoma will increase the number of moles that a person has. So the dysplastic nevi or atypical moles is signs by the irregular border and unusual shape. Its diameter is more than 6 millimeter, having an asymmetry periods, and have more color. We have 2 more shades of color. So it's not homogeneous in the color. Having a flat or bumpy surface. So all irregular moles, or we call dysplastic nevi, is having a higher potential risk to develop pre-malignant and change to become a pre-malignant or become malignant skin lesions. Next. More typical and more specific dysplastic nevi, they call it like red nevus, where the dark pigmented and a starburst appearance with the dermatoscopic view. Misha nevus is a quite a dome-shaped smooth derma nevus often found on the face, and also we call una nevus. It's a papillomatous derma nevus that is shape of a raspberry. Next. Another benign lesions that we know is we call it the egg spots, which is basically a seborrheic keratosis. This very common skin growth can occur everywhere except in the palm and soles. It may look similar in the skin cancer or sunspots. May itchy, may bleed if you scratch it. Having a warty surface, so basically it will always grow in the upper membrane basalis. Next. The sign of non-cancerous skin spots, so we call it sunspot, flat scaly spots that feel through often the color of your skin. Red can be easily scratched out, but it will return in a few days. Mole that we mentioned before, having a brown or black or the same color of your skin, usually around and over. It's usually harmless, even though it may develop the characteristic due to the sun exposure or UV radiations and make it become a pre-malignant lesions. Next. For dysplastic nevi, there is a mole with irregular shape and even color may develop into the skin cancer. Age spots, like a keratosis seborrheic that we have discussed before, is a raised warty area and the skin that feels rough light to very dark brown in color. It's a bit more harmless. Sometimes it get itchy and more. The other benign skin tumor is arteroma, or we call it the epidermolysis. Hemangioma is developed from the vascularization on the skin. Warts of verruca vulgaris may develop from the virus, human papillomavirus, and also papilloma. So this is all about the benign skin tumor that may arise on your skin that can change characteristic if have a majorly triggered by UV radiations. Next. So what is causes skin cancer? More than 95% of skin cancer are caused by exposure to UV radiations. UV radiation most common from the sun, but do not forget that it may come from the artificial source, such as arc welders, blue-coloring lights for such as artificial nails, apparatus. So basically, when you have a pedicure or manicure, sometimes you're using blue-coloring lights. And on solariums, tanning beds. People who have a tendency to having a tanning skin, sometimes using artificial light to tanning the skin. So that's a bit more like artificial source for UV radiations. UV radiation cannot be seen or felt, and it is related to temperature. It can cause sunburn, premature skin aging, and damaged skin cell, which can lead to the skin cancer. Sun damage to the skin starts long before you get sunburn or develop a tan. The damage adds up over the time. Next. So who is at risk? So anyone can develop a skin cancer. So many factors that may increase your potential risk to having a skin cancer for all your skin lesions. So people who have a pale and freckled skin, especially it's easily to burn and it doesn't tan, it may increase their skin cancer. People who have red and fair hair and light color eyes. People who unprotected exposure from UV radiation. intense period of sun exposure and sunburn, people who are actively tan and using solarium, and people who work outdoor without any sun protections. People with a weakened immune system, a lot of moles, dysplastic moles, and also having a history of a previous skin cancer or family history of skin cancer and having a sunspot that may aggravate it and change the characteristic into the premalignant lesions. People with a darker color have more protection against UV radiation because the skin produces more melanin. However, they can still develop skin cancer. Next. Skin cancer do not all look the same, but they're signs. So basically for the diagnosis, we look the sign for looks and feel and different from the other spots. Main characteristics change from the size, shape, color, or texture. Sometimes sore is doesn't heal within a week. You need to be considered is there any changing to the premalignant or not. Sore that itchy or bleed easily, heal and easily to recurrent. So basically, the physical expression maybe need to be more observed in using dermatoscopy or using a biopsy. Next. So this is for an example for the melanoma, the malignant of skin lesion. We call it skin cancer. So you can what you look from the dermatoscope. So basically, we do looking for the any atypical pigmented network. So or you can look for the irregular dots or globules, irregular pigmentation, irregular streaks, or bluish with blue whitish field. Blue whitish field. Next. Other multifocal imaging that updated that we can know that easily help us to diagnosis. So basically, besides using common dermatoscopy that we always use in our practice, we can do the enhanced with a high frequency ultrasound, or you can using optical coherence tomography or photoacoustic tomography, reflectant confocal microscopy, multiphoton tomography, fluorescent laminar optical tomography, and micro MRI. So basically, these are all modalities, imaging modalities that are updated to look further, non-invasive way to make a more certain diagnosis of the lesion that suspiciously as a pre-malignant or malignant lesion. Next. So the picture is this: we shall see the picture A and B is a combined 3D with optical coherence tomography and photoacoustic tomography on the human skin. But a bit more different with the picture C and D, that's a mouse skin. There is same using optical coherence tomography and photoacoustic. So we can see a deeper layer of the skin is more developed. Is there any involvement, changing for the characteristic on the deeper layer of damage? The picture E and F, so basically is implanted. So skin that implanted with the tumor on the mouse skin. You can see from the E, is basically a combined from optical coherence tomography and fluorescent laminar optical tomography. And F is basically the corresponding histopathology. So just implanted a tumor there, you can see a different change from the imaging this diagnostic tool. Biopsy is one of the methods that we can use for diagnostic to make sure, and today having a histopathological examination. So this most common that we use a skin biopsy is a punch biopsy. It's a diameter tools that we try to remove some specimen on the skin that really suspected to having a pre-malignant or malignant lesion. Safe biopsy, we can do that too to make sure that the lesion is a bit more superficial. Because when you go deeper, lower than the membrane basalis, it may leave some scar. Next. Excisional biopsy, incisional biopsy, so basically a bit more variation to exclude all the specimen that we suspected with a bit margin, the outer bigger margin to exclude all the tumor. Next. Another alternative of biopsy, we can use a brush biopsy, fine needle aspiration biopsy, and also exfoliative cytology. Next. The biopsy is a quick and simple procedure with a local anesthesia. For the wound less than 4 millimeter, the stitches may not be used. All specimen tissue will be examined by pathologists on all cancer and the margin of healthy tissue removed during the biopsy. This is maybe the only treatment that needed. Next. Nowadays, they have many so many app in the smartphone to help determine is this a skin cancer or not. So basically, there's some account let you photograph the skin at a regular interval and compare the photo to check the photo changes. So this app is basically help you to record any spot that you worry and you're concerned about and remind you to check your skin. Next. But for some apps, however, the apps is not reliable to detect skin cancer and should not replace the visit to your dermatologist. So it only record and remind you and compare the picture or the photograph you've taken and enter via at the interval. So you can interval time, so you can really remind yourself to see the changes of your skin at the concern, and you can go to the dermatologist. So this is not reliable to detect your skin cancer based on the smartphone app. Next. Staging and prognosis. The stage of cancer described as its size and whether it's spread. BCC really needed a staging because it's don't often spread, but not for the SCC. Some SCC it may require a staging because its size it has spread or not. Vascular biopsy, regular lymph nodes examination, and imaging scan, it may help to determine the staging and the prognosis from this lesion. Most BCC and SCC are successfully treated, especially when we found it and early have a treatment more rapidly. Next. Treatment. Non-melanoma skin cancer treatment will depend on type, size, location, histology of medications, or metastasis. If the excisional biopsy removes all the skin tumor, benign or premalignant or malignant tumor, and do the histopathology examination confirm it's clear for all border, it may not need any other further treatment. Next. Surgery. Surgical excision with a local anesthesia with the most common treatment for invasive BCC and SCC, and also all benign tumor that need to be removed. Recommended margin usually between 2 millimeter until 10 millimeter, depending the types and location of the skin cancer. The surgeon should make a decision which type of excisions, type of closure, to make sure, and it depends on the type and location of the skin cancer. The pathologist checks the margin of skin cancer cells and make sure the cancer has been completely removed. If the cancer cells are found in the margin, you may need a further surgery or radiation therapy. Next. So other modalities for treatment for the superficial skin cancer or the benign skin to other benign or premalignant skin tumor, we can do the electrodesiccation and curettation, or we call it known as electrosurgery. We can do the freezing or the cryosurgery, or using a topical or chemical surgery as a topical creams, or using a photodynamic therapy. So, but these all four other modalities may destruct all the specimen. It will not having any specimen to be examined with the histopathology. So all of these other treatments should be a destruction method. For deeper skin tumor, we suggest that using a micrographic surgery. Next. Micrographic surgery is the procedure done it in stages. They examine each tissue section with a microscope. So during the surgery, the histopathologist come and visit and do the fluxion section and do the examination right away. They keep removing tissue until they see only healthy tissue under the microscope. The MMS or micrographic surgery is aimed to preserve more healthy surrounding tissue surrounding the lesion. There's many types. So basically, from the classical and conventional Breedlove technique, then the standard is more micrographic surgery, or a Munich method, or Turbinger or moving technique. Next. This is a conventional red loaf technique. So basically all the excisional biopsy that we've done with more diameter for the length of 2 until 10 millimeter more wider than the tumor is. They cut it longitudinally, then examine every piece of do the histopathological examinations. So, but it may have some loose end for the tumor underneath the skin. It may grow back there and metastasis from there. The other techniques next. These are standard more micrographic surgery, so basically done in stages. So you can see in the picture, they cut it a first layer horizontally and do the examination of this specimen until it's clear on border and all the sides. If there is something or suspiciously malignant changes there, they cut it more the second layer, then examine it again and cut it again and take the third layer and continuously until all the tumor is the tumor tissue already removed. Next. The Munich method, so basically you cut horizontally the same layer as an MMS. They cut it with both two and cut it horizontally layer by layer until it's totally clear. So if not clear, the surgeon will be, the skin surgeon will be taking more, the specimen more deeper. Next. So Tubinger total technique, so basically a bit more like similar with the MMS, but the surrounding tissue, they divided into two, and both lateral sides, they try to remove it and put it as different objective glass to examine it differently, and all the central limb suspicious lesion, skin cancer, they cut it horizontally and they cut in between in the middle and put in some another specimen to look up. So they make a 4 specimen to really examine. Next.
Dr. Jose, you have 2 minutes left.
Thank you. The muffin techniques, it's basically we cut it a bit more 90 degrees on the side of the tumor. They divide it in two. We try to open it at both sides and removing in the middle of the suspicious lesion. They cut it more, a bit more like 90 degrees to save more surrounding tissue. So the healthy surrounding tissue to make the wound to remove is more smaller. Next. So is it a bit more different from the classical or standard more for MMS and then the muffin technique. So basically the muffin incision is a bit more 90 degrees. And for the more incision techniques is 45 degrees. We can see on both sides a bit more save the surrounding normal tissue using the muffin incision technique. Next. The other modalities is curettation and electrodesiccation. So basically, we do the electrodesiccation by electrodesiccation or electrovulgarization or electrocauterization. So basically, then we curate until it's clear. Next. Cryosurgery, they produce a vehicle using a liquid nitrogen, so basically to freeze and kill the abnormal skin cell and create a wound. In some cases, the produce may need to be repeated, but it is called the minus 120 degrees Celsius, and you can see a bit more 105 millimeter halo, depending the surface that you contacted with his liquid nitrogen as a cryosurgery. So the precising and the penetration is duration of the cryo is depending how much the normal surrounding tissue that healthy it will inflict it to. Next. Topical treatment usually can use immunotherapy like immunoglobulin 5% and topical chemotherapy is a 5FU. Next. You can see this one. I take it from the EPUB. So basically, this is a bit more 2 weeks. 2-week application from lenticule malignant with the immunoglobulin 5%. You can see the result 1 year later. That's a good one. Having a transient post-ambulatory erythema. The big next. This is a photodynamic treatment. So uses of light intensifying medications, topical or injections to kill cancer when it's specially light applied. They inject some chemical Then chemical concentrate at the tumor sites, then ablated with some light using this, for the example, using a transmetal carbon dot chlorine E6 kilorad conjugate, and they blast it with a 660 nanometer laser. What happened? The transmetal carbon dot chlorine in a kilorad conjugate will accumulate under the skin tumor and having apoptosis and necrosis and increasing response for anti-tumor immune response. Next. Radiation treatment, use a controlled dose of radiation. It may treatment for the BCC and ACC that not suitable to remove by surgically. For the last area, for the people who not fit enough for surgery. Next. Sometimes radiation treatment is also used after surgery to reduce chance of cancer to coming back to spreading. Next. So the closure, what will I get for other skin cancer? So life after treatment, regular checkup for recurrent and new skin cancer. Check your skin regularly. Prevent further damage to your skin. Use the sun protection. Next. So the understanding sun protection, yeah. To use sunscreen daily when UV index level more than 3. Because the UV index more than 3 is high enough to damage your unprotected skin. You need to use more than one step of sun protection. How about the vitamin D that we already discussed when you're having a sun exposure? So UV radiation for the sun causes skin cancer, but also best for your source for your vitamin D. Most people get enough vitamin D through incidental exposure to the sun while still using sun protection. When UV index more than 3, you need more spending just a few minutes outdoor or days or week. Next. So what you can do, so if you have a UV index more than 3, so you can slip on clothing, slip on sunscreen, slap on a hat, and slap on sunglasses, seek a shade, and avoid any solariums. Or you can use the like a UV tracker application. It's a free download to look where the time, what duration that you need it. Do you have a sun exposure that have an UV index level more, not less than 3, so it's a bit more safer for you. Next. So the skin tumor treatment is a surgery, gradation, electrodegradiation, and cryotherapy, often leave a scar. So skin treated with radiation treatment, it may change color and appear lighter, darker, depending on your skin tone. So you need to be reassurance for your patient if you want to do this treatment or procedure that they are expecting they're having a scar when you after the surgery, so they need to be prepared for that one. This is my reference. Thank you for the opportunity, and thank you for your attention.
Okay, thank you, Dr. Jose, for the very interesting presentation. And maybe for the audience who want to ask, you can write your question at the chat column. But before that, before the discussion session, it's time to listen to the presentation of our second speaker. Assalamualaikum. Good morning, Professor Khalid Asaf. Good morning, Prof.
Good morning.
Yeah, good morning. How are you?
Fine, thank you.
Fine.
Thank you.
We are very happy and very interested to meet you on this occasion. Before we start, maybe I will read your curriculum vitae first. Okay, Professor Khalid Asaf, a medical doctor PhD. He is a director of the Department of Dermatology and Venereology, head of the Interdisciplinary Comprehensive Cancer Center. He is also Helios, work in Helios Klinikum Krefeld, academic teaching hospital of the University Aachen, right, in Germany, in Krefeld, Germany. Okay, is the education. He studied at studied a medical school at Berlin, Germany. He also internship at the Department of Pathology, Benjamin Franklin Medical School, Free University of Berlin, Germany. He graduated from Department of Dermatology and Venereology, Benjamin Franklin Medical School, at also at Germany. He also a PhD degree at also in Berlin, Germany, and he's also a German board. He got also German board certification at 2003. Next, okay. He got specialist at the Department of Dermatology and Venereology, Benjamin Franklin Medical School, Germany. He also got Oberarzt at the Department of Dermatology at Berlin. He is 2004 until 2008. He is head of the lymphoma section of the Skin Cancer Center Berlin. At 2008, he is habilitation or venia legendi in dermatology in Berlin. Since 2009, he is a director of the Department of Dermatology and Venereology at Helios Klinikum Krefeld Academic Teaching Hospital of the University of Aachen, Germany. And since 2016, he is a head of the Interdisciplinary Comprehensive Cancer Center at Helios Klinikum Krefeld. Since 2019, he also got professor at the Charité Universität Medicine Berlin. Okay. Yeah, this is the university degree of the professor at 2000 and okay, maybe next. He got mini board certified by the German board at 2003. He got board certified by the international board at 2000 and 2005. And then okay, next. So many achievements, right? Yes, he also this is scientific societies of the Professor Khalid. Okay, next. There's so many member of societies, right? He also got research award of the Dr. Sigrid Stanford Foundation Cutaneous Lymphoma at 2016 and at 2014 until 2022. He got Focus Top Mediciner Skin Cancer, is listing of best skin cancer doctor in Germany. Okay. And now academic position, he is senior lecturer and visiting professor of the Charité Universität Medicine Berlin. He also members of the doctoral thesis committee and member of the MD examination committee of the Charité Universität Medicine Berlin. Okay, this is a scientific and medical journal that slide. Okay, so many journal you have already got, and this is also your book. Okay. Okay. Okay, please, the Prof. Khalid, you can start your presentation and you have 45 minutes ahead.
So you see my presentation?
Yes, we can see your presentation.
Okay. So good evening, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Ramadan Kareem. So Dr. Nufliti, thank you very much for this nice introduction. And I have also to thank Professor Tahalele and Dr. Franciscus Solisto for the invitation and also for the organization of this great meeting, and also of my host, Dr. Onata. I have seen it's really an amazing meeting. We have so many participants, more than 300 people, and you organized this around the whole country. And so it's a pleasure for me, and I'm also honored to be invited for this webinar. My topic is, you gave me, is updates in the diagnosis and management of malignant skin tumors in primary care setting. So what are the learning objectives for the next 45 minutes? I want to give you, in follow-up of the nice presentation of Dr. Jose, an overview of the most common types of skin cancer, primarily about basal cell cancer, squamous cell cancer, and malignant melanoma. Regarding the incidence, regarding an overview about the pathogenesis, and especially about the diagnostics and the treatments. Of course, I cannot go in every topic in detail. You know, topic like malignant melanoma for itself can take several hours, but at least I will give you an overview. To get a first impression if it's a frequent topic or not, I brought you the relative table about the relative frequency of skin cancer in Germany. You see on the left the males, on the right the females. And you see on the first place, you have the skin cancers. So the skin cancers are most common cancers regarding the frequency in Germany. Here are included the melanoma and the non-melanoma skin cancer. So they are more frequent in males than the prostate cancer, colon cancer, lung cancer, and other cancers. And in the females, it is also comes before breast cancer, colon cancer, lung cancer, and uterus cancer. So it's a very common topic. And so in my department of dermatology, nearly half of our patients have skin cancers where we are doing the diagnosis, we are doing the histopathology ourselves, we are doing the dermatosurgery ourselves. And in cases where we have advanced cases, advanced stages, we also provide the systemic treatment from chemotherapy till targeted therapy to immunotherapy, which I will show you later. So given this very nice invitation, I was very happy, but my first problem was that I have no idea how it's a situation in Indonesia. I assume it's completely different regarding because of the genetics and the skin types, and maybe also because of the social behavior. It make a difference between people in Germany to Indonesia. So I have looked the recent data if skin cancer itself is any problem in Indonesia. There's a very nice recent study published in the Journal of American Academy of Dermatology last year. And the title is The Global Burden of Skin Cancer, a longitudinal study from the Global Burden of Disease Study. So it's a summary of all registries of the world. And it includes also data from what you see here from Indonesia. In the upper picture, you see the increasing incidence in keratinocyte cancer. That means in basal cell carcinoma and in squamous cell carcinoma. And below, it's the graph for the malignant melanoma. And regarding the colors, if it's blue to green, it means there's very low incidence or increasing incidence in the skin cancer type. And if it's going to red, then it means it's an increasing incidence. And you see on the first class as an example in China, we have a very strong increase of the incidence in keratinocyte cancers. And if you look here, also regarding the melanoma. So how is the situation in Indonesia? And I was surprised, you see it's brown to red. So it's the next color after the red. I was surprised there's an increasing incidence of keratinocyte cancer in Indonesia. And you see here on the right side, it's an increasing prevalence carcinoma per 100,000 persons, analyzed from 1990 to 2017. And you see that Indonesia belongs to the top 10 countries with the largest increase in incidence of keratinocyte cancer. That means basal cell carcinoma and squamous cell carcinoma. However, there is no strong increase regarding the melanoma. So I assume that the keratinocyte cancer, basal cell carcinoma and squamous cell carcinoma is a daily topic for me in Indonesia, and at least it will be in the future, maybe also a very hot topic as is maybe like in Europe. And here you see it analyzes regarding the age of the disease or the frequency in relation to the age. And you see in red are the melanoma And you see the prevalence of melanoma already also in young people. And in blue, you have the non-melanoma skin cancers, the basal cell carcinoma and the squamous cell carcinoma. And you see with increasing age, the distribution of non-melanoma skin cancer is increasing. So non-melanoma skin cancer is usually a disease or cancer of the more advanced age, whereas in the melanoma, you can have it also in very young people. So what's the reason why skin cancers are increasing so dramatically? And this could be caused if we analyze the risk factors. So one is, of course, the UV radiation itself. It is increasing because the ozone level is decreasing in the last decades. So we have more UVA, UVB, and also UVC radiation than we had decades before. And this leads to accumulation of UVA, B, and C leads to mutations, which can cause here in the yellow cells, these are the melanocytes, the melanoma, or if you look here after the keratinocytes, the squamous cell carcinoma. And on the other hand, we have also a change of our social human behavior. That's a picture from Germany. It's from usually when the people were going into the sun, they were covered by clothes. They didn't like to be brown, because the fair skin was a prestigious color. But this changed from the 1950s, 60s to be brown is a sign of prestige. It's a sign of social welfare. So you are able to go far away for holidays and enjoy the sun. And you see here this lady, which has a very massive sun damage with atrophy and with lichenification. And of course, this lady is predestinated for skin cancers. And on the other hand, you see that also children are exposed to sun also from their young age. Of course, the genetics play a role. People who have fair skin are more prone to get a skin cancer. People who have dark skin type, the risk is, of course, much less. And also age. With increasing age, in nearly all countries, cancers itself, and including skin cancers, are increasing. So I want to focus in the next minutes on the most common subtypes, which are, as mentioned already by Dr. Jose, basal cell carcinoma, which accounts of 80% of non-melanoma skin cancer, and it's the most common skin cancer worldwide, basal cell carcinoma. And second, squamous cell carcinoma, which takes about 20% of the non-melanoma skin cancer. And at the end, I will speak at the less common, but which is more severe, it's the malignant melanoma. Coming to the basal cell carcinoma, as I mentioned already, it's the most common form of skin cancer. It usually appears in skin-damaged skin, and usually it has no precursor lesions. So it starts from the beginning as a basal cell carcinoma. In contrast to squamous cell carcinoma, where you have precursor lesions like actinic keratosis, which Dr. Jose has nicely shown. Clinically, there are different types of basal cell carcinoma. This is a typical nodular type, and you see also this typical teleangiectasia. So these dilated blood vessels are a sign of basal cell carcinoma. So it's written here that it's derived from basal cell layer of the epidermis, but it's not really correct, because the real origin of the basal cell carcinoma is from the outer loose sheet of the hair follicle. So we have different types. So we have the sclerotic type, which looks like a scar of basal cell carcinoma. We have this infiltrated type, which also has parts of a scar, or sclerotic type, which usually goes in the deep tissue. and often needs frequent excisions to get a free, complete excision, because you always have in this sclerotic type, single cells are distributed between the collagen bundles in the dermis, or sometimes it goes also to the fat. And here this classical one, like a disc, you have the elevated edge, you have this dilated blood vessels, and you have the steep central part. And what you also commonly see, if it's advanced, although it's growing very slow, but you will often see patients who are coming late to the doctor, and I think there's no difference between Germany and any other country. So we have also these patients where you have this deep ulcerative lesion. So all the lesions typically shows teleactasia, which you can show clinically, or also by dermatoscopy, where you see the blood vessels much more prominent. And this is a sign that we are dealing here with the basal cell carcinoma, which includes at least a biopsy to ensure the diagnosis, and then a complete excision by a micrographic controlled surgery. Here you see the histology and of a basal cell carcinoma, and you see that you have contact to the outer root sheet of the hair follicle. And this is the primary origin of a basal cell carcinoma. It's not the stratum basale of the epidermis, it's always the outer root sheet of the hair follicle. That means if you have, in every place where we have hair follicle, you can develop a basal cell carcinoma. On the other hand, in places where you have no hair follicle, you cannot get a basal cell carcinoma. So that's why you will never find a basal cell carcinoma on the palms or on the soles, because there you have no hair follicles. Dr. Jose has already intensively discussed the different types of excision. We are using, he called it this Tübinger cake. So we are doing a complete remission, clinically a complete remission of the lesions. Most of the lesions, of course, are in the face because it's most sun exposed. And we analyze the center of the lesion. And also we look to the every single part of the edge of the lesion. So from one lesion, usually we have several capsules and several slides we have to analyze. We look to the center, which we need on the one hand for the diagnosis, is it a basal cell carcinoma or squamous cell carcinoma? And on the other hand, we look to the deep part, if it's free or not. And we look to every single part of the edge of the lesion. And this is called micrographic controlled surgery. In the States, the colleagues are doing something like this by Mohs surgery. So the patient is in the operation theater, they're excited, do the excision, and then they analyze immediately. And after half an hour, you have the results. And if there's a rest, make a re-excision. And if there's no rest there, close it. What we are doing in Germany, it's called micrographic controlled surgery. So we take it out and leave the patient for the night. And then the next morning, we have the results. And based on the results, we are doing either re-excision, if one of the margins is involved or not. And if not, we are close it. And this operation are usually done always in local anesthesia. This is an example from your country, from a clinic near Jakarta, published by Sinaga. And you see this is a pigmented type of basal cell carcinoma, excised completely, and then closed by a skin graft. And this is a very nice, also very nice result. This is a patient I have seen about 2 months ago in my hospital. As I mentioned, we have also these cases where patients are coming very late to the clinic. And he told me he has an itching papule on his back. And when I examined the patient, I found this huge tumor with this massive ulceration. And we first, of course, made an MRT. MRI to look if you have involvement of deeper structures, muscles, and bones before starting the surgery. And after having the diagnosis of a nodular and ulcerating basalioma, without infiltration of the deep muscles and not the bone, we made a complete excision by micrograph, this huge rotation flap, and closed it. And I've seen the patient Tuesday this week, and he is fine. And he's coming now every 6 months just for clinical control. Why coming for control? One, of course, is to exclude any relapse, but which is not common if you are using micrographic controlled surgery. But patients who have basalioma have a higher risk to get other new basaliomas. And that's why we are doing this clinical follow-up every 6 months in these patients. So what are doing if the patient it's not possible to remove it by surgery, or as in rare cases, patients has metastasis by basalioma. And there we have in the recent years new systemic drugs which we are using daily, but only for these cases which we can not treat by dermatosurgery or by radiation. And you have two types of drug. One is called targeted therapy. What is the target? We know the pathogenesis of the basal cell carcinoma, and it's based on an activated cell signaling. Sorry. And it's based on an activated cell signaling of the so-called sonic hedgehog pathway. And this pathway is activated by mutations of transcription factors. One of them is PETCH1. And this activated signaling leads to an increase of cell survival. So we have no apoptosis, the cells are living and are dividing very fast. And this is the basis of the basal cell carcinoma. And since we know this mechanism, drugs against the sonic hedgehog, activated sonic hedgehog pathway are developed. And we have so-called sonic hedgehog inhibitors. And these are tablets which we are using just for the extended or difficult cases. Here you see the study using the sonic hedgehog inhibitor. It's called vismodegib. It was the first one. Meanwhile, we have a second one. Its name is secunidegib. And you see regarding the response that about half of the patients have an objective response. And most of them have a partial response. So the aim is to treat the patient, to get a control of the disease, to get the lesions smaller, and maybe at the end to remove it by dermatosurgery or by radiation therapy. So that's an example of one clinic. And you see it's a massive tumor invading the whole midface. And you see it's also going through the nose, through the palatinum into the mouth, where we have these huge tumors. And we have given him this treatment, vismodegib. It's 1 tablet daily. And you see that the tumor lesions are going back, it's reducing. And you see also that internal lesions here are also going smaller. And so for these difficult cases, you can use, meanwhile, this targeted therapy is sonic hedgehog inhibitor. It's a tablet. On the other hand, we have also development of an antibody therapy and immune therapy. It's called checkpoint inhibition. It's a PD-1 inhibition. And I think most of you are familiar with it because this PD-1 inhibition is used for a lot of any cancers, Hodgkin's lymphoma, melanoma. And so since last year, one PD-1 inhibitor, it's called cemiplimab, is approved also for advanced stage basal cell carcinoma. What is the principle of this immune checkpoint inhibition? Is we want to activate the T cells to target the tumor cells. And you have factors which are so-called checkpoint inhibitors like PD-1, like here. And this PD-1, we are using it if we have an inflammation, maybe by an infection, and we get rid of this infection, then we want to stop the inflammation. And then these checkpoint inhibitors like PD-1 are active, and we have no more inflammation. In cancer, we want to have an activation of these T cells, a continuous activation of these T cells and of this inflammation. That's why we have a drug which inhibits this checkpoint, this PD-1, and you have a continuous activating of T cells, which is in nowadays routine treatment for several types of lymphomas and cancers. Here you see it's for melanoma, for lung cancer, for gastric cancer, Hodgkin lymphoma. And here you see for classical Hodgkin lymphoma, you see in this waterfall plot that nearly all patients are responding to this type of treatment. And the first approval of this drug was for malignant melanoma 8 years ago. And at the end, I want to show you an example of an advanced stage basal cell carcinoma, naturally because it's very difficult to define the borders. But on the other hand, it's also difficult to treat by radiation therapy because it's already ulcerated. And this patient was included in this study with 18 weeks, so it takes about 3 to 4 months. I would say clinically, and you have only a scar. So for these difficult cases, we have two of basal cell carcinomas. We have two different types of systemic therapies. One is a targeted therapy with a sonic hedgehog inhibitor, like vismodegib, and the other one is the immune checkpoint inhibition by the PD-1 antibody, like cemiplimab. I will go on to the squamous cell carcinoma. The squamous cell carcinoma, of course, also in sun-exposed region. Typically, you have these nodules, and it's hyperkeratotic. So in contrast to the basal cell carcinoma, which originates from the hair follicle, so it's below the epidermis, and that's why you have clinically no epidermal involvement. And epidermal involvement means like scaling. So in basal cell carcinoma, usually you have no scaling. But in squamous cell carcinoma, it originates from the keratinocytes of the epidermis. You clinically often see scaling. So scaling can help you to differentiate squamous cell carcinoma from a basal cell carcinoma. It's the second most common type of cancer. The increase in the last 30 years is dramatically from 50% to 200% worldwide. Of course, genetics play a role. It's often in older, fair-skinned persons. And the etiology, in most cases, is chronic UV exposition. So what are risk factors that squamous cell carcinoma can do metastasis, usually in the lymph nodes? And they are recognized risk factors. One of them are clinical factors like tumor thickness. If it's more than 2 centimeters, it's a risk for increased metastasis. Localization, the lips, the ears have higher risk than the legs, as examples. Infiltration of deep structures. Then you have histopathological factors like tumor thickness, desmoplasia, or low differentiation. Low differentiation means if you look to the histology, and you cannot clearly clarify that it's originating from squamous cells, from keratinocytes, that sometimes look so anaplastic, so dedifferentiated, and this means low differentiation, and this is associated with worse prognosis. Of course, immunosuppression plays a role. Organ transplanted patients have a risk of 30% to get a squamous cell carcinoma. All patients treated, let's examine for chronic inflammatory disease like Crohn's disease, receiving azathioprine. All patients, what we often see, will have a concurrent hematological disease like chronic lymphatic leukemia. These patients have an increased risk for developing metastasis by the squamous cell carcinoma. Otherwise, this disease is very rarely metastasized. So it's about, let's say, 5% of the patients get metastasized. But this group, especially the patient with immunosuppression, about 30% are getting a squamous cell carcinoma, so every third patient. And about 30% of these patients are getting metastasis. And you see, tumor thickness itself is a biomarker for the prognosis. And if the diameter is more than 6 millimeter, the patient has worse prognosis. And that's why in this group of patients, we need staging like lymph node sonography. Treatment. The primary treatment of choice is the same as in basal cell carcinoma, dermatosurgery, surgical excision. And if not possible, then we are using an interdisciplinary approach, a combination of surgery and radiation. Or here also, we have the possibility in the recent years to use a systemic treatment. Here we have also a PD-1 inhibitor approved for the treatment of advanced stage squamous cell carcinoma. First of all, dermatosurgery, you see, is also done in nicely shown in this picture from this colleague from the hospital near Juge, and it's removed by a complete excision and then closed up. Same what we histologically crossed. In the advanced stage disease, if you have localized disseminated lesions, or if you have organ lymph node involvement, in these cases, you need a combination of therapy like surgery and combination with radiation. And if you have the feeling you cannot control it by these measurements, then you have to use a systemic treatment. In previous years, we have used antibodies against the epidermal growth factor like cetuximab, a classical treatment used in EGFR positive lung cancer. And EGFR is also the epidermal. The remission rate was low, and also the response rate, progression-free survival, only 4 months, was also very low. And in recent years approved, we have here also a PD-1 antibody, which cemiplimab. And cemiplimab was used in this trial, which is published in the New England Journal of Medicine, for 3 milligrams per kilogram body weight IV. They compare 2 weeks and 3 weeks. And I want to show you, just to give you an overview, that you have here metastasized patients with cutaneous squamous cell carcinoma, and here disseminated local cutaneous squamous cell carcinoma. And as a take-home message, you can take with you the same as in basal cell carcinoma, that the response to PD-1 treatment is about 50%. So nearly the half of the patient have a response. And you see the response about 2 or 3 months. And then you can take the decision to go on with the treatment or to stop with the treatment. The disease control rate, including stable disease, is about 70%, between 70 and 80%, which is quite high. And the good thing is, for the 50% of patients who are responding to the PD-1 antibody, they have a very long response to the treatment. So the duration of response is very long. In this study, all the patients who responded were still without relapse, without a further progression. So the response is also, to my experience, for years. And at the end, I will go with you through the malignant melanoma, which is very common and also in the state, clinically different types. You see here nodular melanoma, which is secondary to the superficial spreading part. Here's the same. It's a bit whitish, and it's a sign that melanoma cells and destroying them. And in the places where the melanoma cells are destroyed, it's getting back white or normal skin. And this is, we call it a regression zone. And this is also a sign of malignancy. And here on the below the nail malignant melanoma, it's a acquired type melanoma. And you see, here you see the end of the nail, and it goes further below the nail. So it involves also here the skin part. And this is a sign that it's an invasive melanoma. Here's superficial spreading type here also, and here also. So it's, yeah, as mentioned, it's very common. It's the seventh most common cancer in the States and in Europe. And the status of new case of melanoma has more than doubled since 1973. We have in Germany about 35,000 new melanoma patients every year. And it is also the most common cancer in young adults aged between 25 and 29 years. And among in women with the age between 30 to 35, the incidence is only exceeded by breast cancer. And then the next second cancer in women is the malignant melanoma. We have a continuous increasing incidence, about 4% every year, higher than in any other cancer. In the stage, on average, you have one melanoma just in this every hour. So clinically, we have seen this already nicely by Dr. Jose, and I will make it short because of the time. You can use the ABCD rule to get a feeling if it could be a malignant mole or not. A means for asymmetry. That means if you cannot divide the lesion in two identical parts, then you have an asymmetry, the border to the border, if they are sharply, or like here, it's not sharply demarcated. The color, if you have different types of color, or the lesion is inhomogeneous. And D for the diameter, if it's larger than 6 millimeters, or we say also 5 millimeters. So these are the criteria to differentiate clinically a benign mole from a malignant melanoma. And if you are not sure, what I recommend always to excise it from the beginning, not to control it for 3 months, 6 months, 9 months, because to lose this point of switching from the benign to the malignant disease means the patient has a cancer. And this type of cancer is really life-threatening. So you have your clinical analysis. If you are sure it's benign, it's fine. If you are not sure, you have to excise it. Not to take a biopsy, ideally to excise it always completely.
Excuse me, Prof, maybe you have 2 minutes left.
So you have different types. So you have the in situ melanoma, which means it still has no invasions below the epidermis. This has very good prognosis and complete types of superficial spreading malignant melanoma. And then you have the acral type, which is especially in pigmented people in Asia and also in Africa, the most common type of malignant melanoma. And we have the nodular melanoma. Nodular is mostly secondary to a superficial spreading melanoma. But you have also amelanotic melanoma, and these lesions have no pigment. That's why it's called amelanotic melanoma, and are usually very late detected, and these patients therefore have usually a worse prognosis. So amelanotic melanoma exists and should be always a differential diagnosis to other amelanotic cancer lesions like Merkel cell carcinoma. You see the stages. You see here, till stage 2C, it's skin limited, and the differentiation is by the thickness of the infiltration, and of course the prognosis is getting worse. If you have deep infiltration, it's getting worse as a prognosis. And then you have the stage 3 and stage 4, where you have already metastasis. Stage 3 means lymph node metastasis, and stage 4 means organ metastasis. And what we are doing always in melanoma from the beginning from stage 1B, because the risk for lymph node metastasis is increasing from stage 1B, we take a lymph node out. It's called a sentinel lymph node. It's a regional lymph node of the skin area, and investigate it if it's involved or not. How we do this? You see, we inject technetium. Usually it's done in the nuclear medicine department. And then this technetium, we can use also the color methylene blue, is going to this regional lymph node. And then here you are in the axilla in the region. And you can detect this technetium here by this device, if you have really found the sentinel node or not. And then you excise it, and then you analyze it. And if you have involvement of this lymph node, then the patient is categorized as stage 3. And then you do a total CT scan and MR of the head to exclude stage 4. And these patients usually have a very bad prognosis and need treatment. So the principle is early staging, complete excision. That's the only chance for these people to be healed. However, when the patient have already a metastasis like lymph node or organ, then they have a high risk for disease recurrence. And many of these patients ultimately will also die of metastatic disease. And at the end, I will show you 2 systemic treatments options we have. It's a big field. One is a targeted therapy. It's the same as in basal cell carcinoma. A targeted therapy, I had shown is the sonic Hedgehog inhibitor. Here we know the target, the BRAF and the MEK. And BRAF is mutated, this gene, in about 50% of all melanoma patients. And if it's mutated, we give the patient a so-called BRAF inhibitor. It's also tablets. And by this, you see very fast remission of the tumor node. And that's a metastasis, a huge metastasis on the breast. She had also metastasis in the lung and on the head. And you see, just within weeks, we have a very good response. And here you see a PET CT. And you see this patient had a lot of metastasis, organ involvement, liver involvement. And you see here also the bones, disseminated severe bone involvement. So 8 years ago, if we had seen such a patient, he usually will die after 3 months, a maximum of 6 months. And this patient was treated with targeted therapy with a BRAF inhibitor, and you see nearly complete remission of this organ metastasis, and also a very good partial remission of the bone metastasis. So you can combine this treatment, of course, also with the radiation therapy. And I will tell you later how long this patient can live. And of course, we have the PD-1 antibody, which was first approved for the malignant melanoma. This is an example, nivolumab, but we have also others. And you see, we have nearly a doubling of the overall survival rate in these stage 4 melanoma patients with organ metastasis. And if you look to the recent data, the 5-year survival rate with melanoma patients in stage 4 who have overt organ metastasis is meanwhile 66%. So when I started dermatology, we had a melanoma patient who had metastasis in the organ. Usually he would die within 6 months. So it was always very disappointing. And I mean, honest, I didn't like this tumor when I started dermatology. But meanwhile, we can deal with this aggressive disease. We can treat the patient. We have targeted therapy, and we have checkpoint inhibitors. And in recent studies, we have also combinations of targeted therapy with checkpoint inhibitors, which are increasing the overall response rate and also the survival rate. And we have a dramatic development of clinical studies in the last year in the melanoma field. And every study nearly increases or improves the outcome of these melanoma patients. So here, this picture you see just as an example. There are meanwhile much more targeted therapies and immune checkpoint inhibitors. So I come to the end and I want to summarize. The incidence and the prevalence of skin cancers is increasing disproportionately among different demographic groups and regions, including, as I have shown in the beginning, also in Indonesia. Early detection and surgical removal is the key of complete healing in most cases. However, despite many cases being preventable, cutaneous melanoma remains the most serious skin cancer worldwide. But fortunately, we have novel targeted therapies and immune checkpoint inhibitors, as I've shown you, which provide a huge progress regarding overall response rate and overall survival in advanced skin cancer, including basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. And by this, I come to the end. And thank you very much for your attention.
Thank you, Prof. Khalid Asaf, for the very clear and interesting presentation. And now we will enter the discussion session, and I will read the questions that have been entered in the chat column. Okay, first, there is a question for Dr. Jose from Dr. Ivan. Yes. Why people who have red hair have more risk to get skin cancer? And the second question, when we decide to use photodynamic treatment or radiotherapy skin cancer? Please, Dr. Jose. Excuse me, Dr. Jose, you can unmute.
Sorry, thank you, Dr. Ivan, for the question. So basically, the people who have a red color or fair skin or a very light eye color develop less melanin. We call it melanin. So basically, the melanin is protect our skin from the UV radiation that may trigger as the main factor that cause as changing the skin characteristic into the become a pre-malignant or malignant lesion. So people who have a bit more darker color skin tone, a bit more having produced more melanin, so it can protect more from the UV radiation. It may have a less potential risk to develop any skin cancer. The second question is about, sorry, Dr. Fitri.
The second question is when we decide to use photodynamic treatment or radiotherapy for skin cancer.
So the main treatment for the skin cancer or skin malignant or benign who have a tendency, a species to become a change characteristics to become a pre-malignant or malignant lesion. Is basically we do the early diagnosis and having a surgical removal. So after surgical removal, the specimen should be histopathologic examined to make sure all the specimen is clear, having a clear border, a clear base, that if they needed another surgical removal or other optional treatment, such as radiation, such as any other alternative. So the main treatment should be an early detection and the surgical removal as a complete treatment.
Okay, so the first is the early detection, right?
Yeah, when we use a PDT, basically a PDT or another alternative radiation or topical treatment is basically if the skin or location of the skin tumor is not operable, suitable for operations. So for people who are not very suitable during the surgery or the location of very difficult cases that the Professor Asaf has shown you in the middle of the nose or the facial is very difficult to have a surgical and closure afterwards. So we are considered to do the other alternative treatments such as a PDT or other systemic or oral anti-PD-L1 inhibitor, such as. That's it.
Thank you for the good answer, Dr. Jose. Next, also the question for Dr. Jose from Dr. Leona. How to tell the difference between a normal mole and a mole that has the potential to become from malignant, and what should we do if we have this mark?
Yeah, so basically that professors also showed in the last presentation. So we have a tend to have a melanocytic navy. It may change the characteristic to the UV radiation. So basically, you need to look the sign if any changes there. So starting with the ABC of A for asymmetry. So you can see any shape for this skin lesion that you're concerned about. Is it changing the shape, the size, the border is it irregular or markedly demarcated or not? The color, any change or any adding the same color, a bit more than two different shade of color. The diameter is growing up or is a bit more than 6 millimeter. Is a bit concerned that to be having a pre-malignant changes, or E or something you can look for as a telangiectasia, so any ulcering or any bleeding or repeating bleeding and heal process there. So it may all these changes will be a bit more like a sign that they're having a change characteristic from this mole or navy. It may turn to be a pre-malignant or malignant lesions.
Okay, so A, B, C, D, right? Yeah. Okay, another question. If we are a doctor in primary care, if a benign tumor is found on the skin, what type of benign tumor can the doctor in primary care treat, and which benign tumor should be referred to a dermatologist for the treatment?
All benign tumor based on the early detection and early examination. So you have a proper diagnosis is an early tumor or benign one. So if this all the benign, then you are sure without any. If you're not certain, do the biopsy, or you can refer to the dermatologist to do the totally surgical exercise completely to do the histopathological examination afterward. So the thing is that early detection for the proper diagnosis for this lesion is a benign or pre-malignant. You need to really pay attention to recognize it, well identified it, before you make a decision. Is you want to remove it, or you want to take the total excision and with the histopathological examination. Because if you want to destruct it and remove it with the other modalities besides surgery like electrodesiccation or cryosurgery or any topical treatment, so you may not left any specimen to identify precisely what is you're dealing with. So you need to really decide as early detections and early identifications. This is really benign or not. If you're not certain, better you consult with dermatologist to make sure having a proper treatment for this precaution that the suspected lesion.
Okay, thank you, Dr. Jose. Question for Professor Khalid from Handi Siono. Vitamin D has a role in skin, namely proliferation, differentiation, immune regulation. Should we take vitamin D regularly to maintain skin health? And should we avoid sunlight because of fear to photodamage skin and potency to skin cancer?
Yeah, thank you very much for these interesting questions. Vitamin D, of course, has a role in the skin. It's already produced in the skin, vitamin D, and it's very important for the immune system, immune regulation against not only cancers and also infections. So to check and to have normal vitamin D levels is of course the aim. But on the other hand, there are, if you ask if it has an anti-cancer role, because vitamin D is shown in several studies that it could help the progression and relapse of cancer. Here, the data are not really clear. So there is no basis to recommend vitamin D in higher than the normal dose for cancer treatment.
Oh, okay. And should we avoid sunlight because of fear to photodamage skin and potency to skin cancer?
No, of course not. We need the sun for vitamin D. We need it for our welfare to be healthy. So sun, of course, is very important. But we have to deal with the sun consciously. So to get no sunburns, and so to check where we are and at what time we are in the sun. We don't need to lie on the beach between 12 and 3 o'clock continuously. And so we have to deal consciously with the sun. The sun, of course, is very important. And on the other hand, we have to also consider our skin type and about how strong is UV radiation. So which place of the world you are staying. We have places where you have a very high UV radiation and places where we have low. And the skin types is decisive. And of course, at least sunburns should always avoided, not to get a skin cancer. And of course, on the other hand, sunburns, too much sun is also inducing skin aging. So there are different reasons to deal reasonable with sun. But of course we need.
Okay, thank you, Prof. Khalid. Is another question to you. Is there, from Dr. Leona, is there a relationship between food and an increased risk of skin cancer? And what food should be avoided to reduce the risk of skin cancer, and what food should be consumed to prevent skin cancer?
That's a difficult question. Till now, we are not aware of any food which increases skin cancer. So there we cannot give a recommendation. On the other hand, we know that regarding to prevent skin cancer, food can help, especially vitamin B3. So vitamin B3, it's called nicotinamide or niacin, which we find also in the rice, in the skin cancer. The New England Journal of Medicine 5 years ago, which showed by taking nicotinamide, which is vitamin B3, twice daily, 500 milligram, reduces the risk of basal cell carcinoma or squamous cell carcinoma between 20 to 30%. So vitamin B3 is also a type of prophylaxis and reduces the risk of skin cancer. And we prescribe it also for our patients.
Okay, so the food with vitamin B3, right? Yeah. Okay. Is there a question for Professor Khalid from Dr. Ulfabia? What are the referral indication for malignant melanoma?
So every patient who has a suspected mole should be referred for melanoma. Every patient who has the multiples of moles, who have multiple mole syndrome, that means we have more than 100 moles, should be also checked for malignant melanoma. Patient who has a positive family history should be checked for malignant melanoma. So these are the main reasons to refer a patient for malignant melanoma. With rare, but maybe you see it in your syndrome, where these young patients have a very high risk to develop squamous cell, basal cell cancer, and also malignant melanoma. I hope I got the question right.
Okay, thank you, Prof. Also another question for Prof. Khalid from Dr. Ivan. From epidemiology data show us if non-melanoma skin tumor is more dominant to affect people with 19 age than melanoma. Why non-melanoma more dominant? Thank you, Prof.
Sorry, I didn't get it, the question.
From epidemiology data show us if non-melanoma skin tumor is more dominant to affect, it means 19, it's people with age 19 yeah, than melanoma.
So
Why not
the question is why we have more non-melanoma skin cancer than melanoma. I think the cells like keratinocytes and the basal cell cells of the hair follicle are more sensible to UV radiation than the melanoma cells, than the melanocytes. This could be a reason why we have much more non-melanoma skin cancer than melanoma. And of course, there are also some genetic backgrounds because we have also melanomas in not sun-exposed areas. So the genetic background plays a major role in melanoma pathogenesis than in the pathogenesis of the non-melanoma skin cancer.
Okay, thank you. Still another question for Prof. Khalid from Felinda Huang. The African has higher melanin in their skin, so that their skin darker than Indonesian. I have heard that the higher melanin has a role to skin cancer protection. What is the other cause of the skin cancer of African beside the sunlight?
That's right. First of all, Africans have very rare malignant melanoma compared to the Western regions. But if they develop melanoma, it's more common acral melanoma. So they usually developed in their palms and soles. And I think that here, as I mentioned before, the genetic background plays a major role than the sun exposition. And this is for, of course, speaking for the most African patients. I'm not speaking about people with albinism and so on.
Okay. Okay. No other question. Maybe the last question for you, Prof. Asaf. I want to ask: do you use RCM on a regular basis for screening for clinically suspicious lesion in your hospital? Also, do you think the use of RCM will significantly help in your management as compared to routine clinical and dermoscopy examination?
So your first question was about the screening. Yes, we are doing the screening for skin cancer. It's per rule in Germany every 2 years, where we do the complete body examination, including the dermatoscopic analysis.
Oh, okay. Okay, other question, and maybe because the limitation of the time, so I have to close the discussion session. Thank you, Dr. Jose and Prof. Khalid for the presentation and discussion today. And so for the conclusion, the skin tumor is ranged from benign lesion to aggressive and malignant tumor, and the therapy is from surgery, radiotherapy, and also many therapy that we can use. And after this, the time I go back to Dr. Dave.
Yes, thank you so much to Professor Asaf and Dr. Jose for the very interesting talk and discussion about updates in common dermatological tumors in primary care. And also a very thank you to Dr. Nufitria for moderating this scientific session. Now, we would like to continue our schedule today with a symbolic certificate submission to Professor Asaf and Dr. Jose. And please, I would like to request assistance from the IT team. And this symbolic certificate submission will be with Professor Paul Tahalili as well.
Yeah. This is for, oh, Professor. Okay.
Thank you very much.
Lieber Herr colleague, Professor Khalid Asaf, it is a pleasure for me and our institution to give you these certificates as a token of our gratitude and appreciation to you. Thank you very much once more. And then, ich hoffe, Sie sind gesund und glücklich beim Fasten. Und ich freue mich sehr und bedanke mich für Ihre Beitrag und Teilen Ihrer Wissens, essentially Ihrer klinischen Erfahrungen in Dermatologie. Once again, vielen Dank, bedanke mich, gesund und glücklich. Bye.
Bye. Thank you very much, Professor Tadede. It was a pleasure and an honor for me. Thank you.
Yes.
Probably the IT team, would you also display the certificate for Dr. Jose?
Okay. The next certificate.
Tim IT, boleh minta tolong?
Yes. Dr. Yose is our staff. He is a docent of the dermatology and the head of the department of dermatology, medical faculty of Widya Mandala Catholic University. Dr. Yose?
Ya, Prof.
Yeah.
Terima kasih, Prof, atas kesempatannya.
Yeah.
Semoga bermanfaat, Prof, ilmu yang kita berikan.
Where is the certificate? Tim IT?
Prof, sepertinya mungkin untuk Dr. Jose belum bisa di-display sekarang. Prof.
Okay. Thank you very much, Dr. Yoshi.
Okay. Yeah.
That is our appreciation for you. And once again, thank you.
Yes, before we close the meeting, is it possible to have a very quick virtual photo session? I would like the assistance from the IT team to quickly take a virtual photo shoot of us. For the participants, I would like to request for you to turn on your camera.
It's good.
Oke, mungkin tim IT boleh ya sambil itu cepat karena kita ngejar buka puasa juga ini.
Sudah. Tim IT sudah. Halo. Oh, dia buka puasa. Ya udahlah. Siapa yang bisa screenshot mungkin? Coba tolong.
Sudah, Prof. Sudah. Saya yang screenshot tadi. Ya.
Once again, thank you very much, Professor Khalid Asaf. See you later. Next time I'll invite you again. Thank you very much.
Thank you. Thank you too.
And Dr. Yose, also Dr. Nur Fitria. Terima kasih. Thank you very much for your participation as a moderator.
A friendly reminder to all the participants to fill the attendance on the given link written on the chat box. And so this is in regard for the certificate. Certificates to all the participants will be sent to the emails that you guys used to register for this webinar. And on behalf of the committee, I would like to apologize for any errors or wrongdoings during this webinar. And last but not least, I, as the host for today's webinar, would like to say goodbye. I wish you all the best, stay safe and stay healthy.
Okay.
Thank you, Professor Paul, Professor Asaf, Dr.
Okay.
Dr. Nurfitri,
Thank you.
and dosen. Terima kasih banyak.
Yeah.
Dan
Thank you. Thank you so
Thank you.
much.
Thank you very much.
Bye-bye.
Thank you.
Bye-bye.
Ya, berangkat nih.
Terima kasih, Prof.
Thank you, Prof.
Thank you.
Terima kasih, mohon izin pamit.
Terima kasih Dr. Puji juga bersama teman-teman PHC. Terima kasih Dr. Nufitria, sorry.
Prof. Terima kasih, Prof.
Terima kasih ya.